Right. Good afternoon. This is Ndumbe-Eyoh, the National Collaborative Center for Determinants of Health. We are here today for the webinar entitled Health Equity in the Field, Reflections for Students and Early Career Professionals. Before we continue, I'm just going to ask our presenters to please mute yourself if you're not speaking, and you can do so using *6 and #6 to unmute. Just as a reminder, today's webinar, including the chat box, is being recorded. My name is Ndumbe-Eyoh. I work with the National Collaborative Center for Determinants of Health as a Senior Knowledge Translation Specialist. I'm joined on the line with my colleague Danielle McDonald, who you'll see in the chat box, and you should have received most of your communication for her. I currently live and work in Toronto, which is the traditional land of the Huron-Wendat, the Petun First Nations, the Seneca, and most recently the Mississaugas of the Credit River. Today's webinar is brought to you by the National Collaborative Center for Determinants of Health. Most of you are already dropping notes in the chat box. Please use that space to send in any questions throughout the course of the presentation, and we'll be pausing at different times to respond to those. If you have any resources you'd like to share with us as well as other participants, you can also do so in the chat box. So our advisors today are Connie, Clement, Christine Johnson, and Lee Much. I'll be introducing them in more detail later on, but I'd like to thank the three of you for joining us on today's call. So our particular focus at the National Collaborative Center for Determinants of Health is to support public health practice in the area of social determinants of health and health equity. And we do so by translating and sharing evidence on what works to influence the social determinants of health equity across the country. The NCCDH is in Mi'kmaq, which is the ancestral and unceded territory of the Mi'kmaq people. And I think I'll just pause and it's becoming commonplace, and I think that's a very positive thing, for organizations and individuals to really acknowledge the spaces in which we occupy, the spaces in which we live and work. And I think this is it's a small but important step in improving relationships with Indigenous communities, and also calling on us all to reflect on our relationship with this land and start to think about how in our ongoing work and in our daily lives we can decolonize our lives and our ongoing practice. The NCCDH is part of a network of 5 other NCCs. The NCCs all focus on a different practice area in public health. What we have in common is our focus on really supporting public health practice to be more evidence-informed. At the NCCDH, we think about evidence in fairly broad ways. So we're often drawing not just only from the published and research evidence, but also really pulling from practice-based knowledge as well as sort of tacit knowledge from practitioners and researchers. The other NCCs focus on Aboriginal health, and that's out in Prince George, BC. We have an NCC which focuses on environmental health, which is based out of Vancouver. In Winnipeg is the NCC for infectious diseases, and McMaster University in Hamilton is home to the NCC for methods and tools. Another NCC based in Quebec focuses on healthy public policy. So if you're interested in any of those areas, you can find out more about all those centers by going to www.nccph.ca, and that will link you out to all 6 NCCs. So before we continue, we'd like to get a sense of how much of a focus health equity and the social determinants of health are in your program. And from the introductions, I think we have a mix of students, some faculty members, and people who already work. And so just think about whatever role you occupy, how much of this is a focus. Great, thank you. So right now we have some great results coming in. About 65% of people are saying it's a major focus of their program. A few people saying it's a little, it's about 36% right now, and no one's saying not at all, so that's really positive. If you're using NCC materials in your courses in any way, we'd love to find out what you're using, how you're using that, and you can send me a note about that. My email will be at the very end of the presentation. Great, thank you, Danielle. So So the focus of today's webinar is to really talk about health equity practice. So it's really positive to see that health equity has been, and it's an important part of public health education and public health practice. So what our presenters today will be doing is talking about what health equity practice looks like from their specific organizational context. Our presenters today have worked with municipal public health organizations, have worked provincially, and also at a national level, and really bring a very wide range of experience, and they'll be speaking to that today. We've also asked our presenters to give us a sense of how you integrate health equity into everyday public health. And there's been a move across the country for a lot of public health organizations to have very specific roles where it is, those roles are mandated to support the organization's work in terms of the health equity practice. So really think about, what if that's not your role? How do you bring this perspective into your everyday work? And our presenters are going to end with this idea of leadership and thinking about how students and early career professionals can demonstrate leadership in their work. So before I go any further, I'll mention that you have noticed from the slide decks you received that our presenters are not using a lot of slides, so we're really going for a dialogue-based approach, and they'll be doing that by responding to a series of questions which address the objectives. I'd like to mention that we have a new resource out at the NCCDH. It's called Key Public Health Resources for Master Public Health Students, a curated list. And while it says Master Public Health Students, I think it's a really nice guide to NCCDH resources for anyone, for students specific, like it could be masters or otherwise, masters of public health or otherwise, and it just helps you navigate our resources a little bit better. The curated list includes our introductory resources, which is our Let's Talk series, which are really short, concise documents on introductory health equity-related concepts. It also includes links to various case studies we have worked on. You can download that in English or French from our website. In addition to webinars like today, we also have, you can also access a range of resources through the NCCDH website. I'd like to point you to our resource library, which is what we're calling a one-stop shop for public health resources on the social determinants of health and health equity. So it's just a nice way to start to figure out what the lay of the land looks like. We also support a community practice which has been dormant for the last few years, but we're in the process of revitalizing that community, and we're hoping to relaunch in the summer of this year. One of the things which we would love for the community is to have a stronger member voice in the community that we did during its very first iteration, and through that we are going to be working with volunteer community moderators and facilitators. So if that is of interest to you, again, you can send me a note. I'll also mention that the NCCDH is currently recruiting new board members, and we have usually had a student board member, and that information will be available on our website later this week or next week. So if that's something which is of interest to you, please look out for that. All right, so now I'd like to introduce our three presenters for today. Our first speaker, Lee Much, is a clinical nurse specialist with the Population and Public Health Program of the Winnipeg Regional Health Authority. Prior to her role as a clinical nurse specialist, Lee worked as a registered nurse in a variety of areas. Throughout her career, Lee has focused on the health and well-being of Indigenous peoples. In her current role, Lee uses Indigenous ways of knowing with a focus on health equity, provides clinical expertise to guide public health nursing practice in the area of healthy parenting and early childhood development and Indigenous health. Thanks for being here with us today, Lee. Our next presenter is Christine Johnson, who is the Health Equity Lead at the Nova Scotia Health Authority. Christine works within the Public Health Science and System Performance Unit. She holds a Bachelor of Science in Human Nutrition and a Master of Science in Applied Human Nutrition with integrated dietetic education. Prior to coming to public health in 2014, She was an assistant professor in the Department of Human Nutrition at St. Francis Xavier University for 9 years. She has active engagement and leadership in province-wide initiatives, such as serving as co-chair of the Health Equity Work Group of the Public Health Association of Nova Scotia. Hey, Christine, thanks for joining us today. Connie Clement is the Scientific Director of the National Collaborative Center for Determinants of Health. Connie joins the NCCDH in January of 2011. Previously, she was the Executive Director of Social Ventures Partner Toronto, a venture philanthropy collaborative, and Health Nexus, Nexus Santé, which is Canada's premier health promotion consultancy. She was Director of Planning and Policy at Toronto Public Health when 6 public health units merged, and previously held varied health promotion, sexual health management, and frontline positions. Connie has a Bachelor of Science in Biology and Sociology from Trent University. And one of our speakers, who you may have seen on the early announcement, Shana Calix, was not able to join us here today. So I'm going to get started, and Christine, I'm going to have you get us going here. So our presenters will be responding to the question, what is the nature of your health equity practice? So we're going to start with Christine, and then Connie, you're up next, followed by Lee.
Great. Thanks, Sume, for the warm welcome, and I'm so very happy to be here with everyone today. I want to start by first acknowledging that I am also living and working in Mi'kma'ki, which is the traditional ancestral territory of the Mi'kmaq people. As Sume mentioned, I've been in the role of Health Equity Lead for 4 years now with Public Health, initially within a district health authority, and now work in a more provincial scope within our fairly new Nova Scotia Health Authority. Public health in the Nova Scotia Health Authority is a program area, a provincial program area, and we operate within 4 zones, as well as our one provincial unit known as Science and System Performance, or SSP. That unit in particular was established to provide scientific and technical advice to support our overall program and to achieve consistency and quality. One other thing I wanted to mention is that our work in public health is guided by our provincial public health standards and protocols, and in those documents, health equity has been named as a foundational value as well as a cross-cutting protocol, meaning that it's an approach that we want to take and a lens we want to use in all the work we do, regardless of what content area or focus you might be working in. So first, generally, in a health equity specialist role, my work definitely focuses a lot on developing processes, tools, as well as learning and development initiatives in order to build our collective capacity to embed health equity in our work, as well as stated in everyone's roles. Some projects I engage in either focus on health equity explicitly or bring a health equity lens to a topic area. So one other thing that I find very exciting about our current reorganization and structure is that public health also has the opportunity to connect and influence other parts of our health system and advocate for the use of a health equity lens beyond public health. So when I wanted to describe some of the specific things that I do in my everyday work, I use the 4 roles for public health action, public health equity action from the National Collaborating Center. It's a nice way to kind of organize and think about our work. So I'll just give a few examples under each broad category. So under the role of assessing and reporting on the existence of health inequities or evidence-based practices to build health equity, some recent activities that I've been involved in include conducting a synthesis of our current oral health surveillance data and looking at that through a health equity lens in order to identify priority populations that we need to be focusing our efforts on and partnering with. Another example is doing an assessment across the province of what is our work in the area of housing as a social determinant of health? What is it that we are doing? How do we approach housing? You know, at what level? Are we looking at emergency shelters, or are we working on an affordable housing strategy? Some other examples would be getting to engage in original research projects with community and academic partners, and on the books are plans to develop our health equity indicator framework for the public health system. Under modifying and orienting interventions, again, back to the topic of oral health, one of the projects I've gotten to work on recently is a situational analysis of looking at what is a proposed role for public health within oral health, and how do we strategize and shift our focus to move our emphasis in this area more upstream. Another good example was taking our provincial public health equity lens and adapting that for use by health services planners. A lot of what I do also gets to be done in partnership. So some examples include partnering with the Canadian Centre for Policy Alternatives to calculate living wage, as well as co-chairing our health equity working group of our Public Health Association, which brings together sort of diverse voices interested in equity from multiple perspectives. Another area that's recent and I'm very excited about is partnering again with community and academic researchers in the area of environmental racism to bring that knowledge and understanding into the public health realm. And of course, the last one being participating in policy development. So in this realm, a lot of the work that I do, I'd kind of categorize as knowledge translation and supporting evidence-informed decision-making at various levels. So this might include local, provincial, and national levels. And some recent engagement has included being involved in a campaign to push for, it's a provincial campaign to push for federal investment in universal school meal programs. So that just kind of gives a bit of a snapshot of some of the exciting work I get to do on a day-to-day basis.
Thanks, Christine.
Hey, Connie, you're up next. Thank you, Christine.
Yep. Thank you. So I'm going to chat a little bit about my role at 3 different jobs, if I can fit that in. And so currently at the National Collaborating Center for Determinants of Health, our role really is to translate knowledge. So we're trying to help particularly the formal public health sector by helping you and the organizations within which you work. How can we help you advance health equity better in terms of your knowledge, your skills, the practices that you engage in, the organizational and system context or setting within which you work? How do we shift all of that? And so to talk a little bit about that, I'm going to go back when I did work directly in public health. The bulk of that time was at Toronto Public Health, at frontline, at middle management, or at program consultant, at middle management, and at senior management over a long period. I think in the frontline, really, my work most of all was to be inclusive, to be responsive, and to work with community, not for community. And so that meant integrating community and designing programs, being sure that there weren't barriers to access, that we could find a way to fund transit or childcare if we were asking people to engage, and being really responsive to different community needs. And as a program consultant and a middle manager, I was able to advocate for staff training, so taking on anti-racism training back in the 1980s and into the 1990s. How do you build in both recognition of determinants of health, and I will say at that time much more of our language was determinants, and I think much more of our analysis was determinants rather than equity. And so when we were running grants programs, how do we help make sure that more politicized, more small community groups that were trying to do upstream work could get access to funding, as well as programs that were either more formalized or more service-oriented. When I became a policy director, that's where I started to bring in a health equity analysis more. I think about some of the examples I worked on, advocating, doing a lot of policy advocacy, trying to get funding for dental care. I was pleased that Christine named that. Initially for children who had whose families were income disadvantaged, and then for adults. How do you use the popular media to tell that story? How do you partner with community groups? How do you step into leadership from the side or behind so that community groups can take leadership on a whole range of issues that may affect populations that are more marginalized more than others? When I left Toronto Public Health, I went to Health Nexus, which many of you will know through the Health Promotion e-bulletin or Le Bloc Note. And there I was helping public health as an intermediary. And I think, again, in each thing that we did, we were able to find ways to bring in attention to either determinants of health or equity. So in the Ontario Stroke Strategy, working particularly with primary care, for instance, we were able to develop resources to get them to think about individuals' needs differently, to not see people always as a patient, but to see them as whole individuals, and how do you start to respond to different needs. We put together an early database of information and resources that would have helped people working in stroke care, particularly in prevention, to help with immigrant settlement or housing issues or whatever, and moving away from lifestyle into more whole lives, if you would. And I think there I might stop for the moment when I think about the nature of my work. But I will just say that it wasn't until I got here that I really, my understanding of equity and how public health can shift equity really deepened and changed. And I would have told you I'd been doing this work for 30 years already. And so it's a very growth piece for us all, I think. Thank you.
Thank you very much, Connie. So up next, we're going to hear from Lee.
Okay, hi everybody. Thank you for inviting me to participate. I just want to say that acknowledge that I'm living and working in Treaty 1 territory, which is the traditional lands of the Anishinaabe, Cree, Ojibwe, Dakota, and Dene peoples, and it's homeland of the Métis Nation. In my current role, I'm working as a clinical nurse specialist in population public health for the Winnipeg Health Region. Some years ago, our health regions were amalgamated, so now my region in Winnipeg also includes Churchill. And I put this map up so people who aren't familiar with Manitoba or where Churchill is in Winnipeg, that's the distance that we're apart. It's about a 1,700 kilometer distance, and pretty much strictly fly in at this point. And Churchill is a bit remote. It's northern, and I think it's about $1,300 on a good day to fly up there and back. So the employment up in Churchill is fairly, I would say, seasonal. There is a port there, and they rely on tourism. See, about a year or so ago, the railway was discontinued, and now there's a dispute between the company that owns the railway and the government about who's going to pay to fix it. But in the meantime, the people of Churchill are very stuck, and it's costs a lot. I think I read that at one point a head of broccoli up in Churchill was $9, and I'm assuming it's a lot more now. So that's sort of what Churchill's like. And the other part of my job, I work in Winnipeg. I work and live in Winnipeg. And this map just shows you sort of the gaps in the inequity that people in Winnipeg might experience. So on the two community areas I work in, primarily are the one that's sort of red on the male life expectancy map and the orange one on the female life expectancy map. And then I work in the area that's to the west of that as well. So those two areas experience probably the most inequity in the city, and comparatively have lower rates of life expectancy than other areas of Winnipeg. So in the Point Douglas area, for example, the red area, they also have higher rates of suicide, higher rates of chronic disease, highest rates of poverty, the lowest rates of breastfeeding. And it's also, I don't think, any coincidence that those are the areas that have the highest and the largest Indigenous population. I actually live in Point Douglas so that I'm connected to that community in a different way, and I do that purposefully so that I am connected. Another part of my job is supporting a program called Prenatal Connections, and it provides services to women who travel from birth, specifically from the Kavalik region of Nunavut. So those women can be in Winnipeg for four weeks, sometimes longer, depending. I'm also a program specialist in Indigenous health, and I think we can all appreciate that Indigenous people experience inequity in a number of ways. I'm very fortunate that I get to work with Dr. Marcia Anderson, who, if you don't know who she is, she's like a celebrity, and she's also a leader in Indigenous health. So we work together very closely, and we work with others in the region to address gaps in Indigenous health. We've done a lot of work around addressing racism in the healthcare system through staff development, focusing on anti-racism. We've focused on the calls to action of the Truth and Reconciliation Commission of Canada and the United Nations Declaration on the Rights of Indigenous Peoples. We've also partnered in public health with Indigenous health programs, which is another program offered in our region, to develop a plan for reconciliation based on the calls to action of the TRC, which we anticipate will be adopted. Our provincial health system is undergoing some significant changes right now, so we don't know that that will be a regional approach, but we're hoping it might be provincial. And as a clinical nurse specialist, I really support public health nursing and other staff to bring things forward. So they really bring forward issues, areas of concern, or things that they're seeing in their practice. They see inequity in the areas I work in anyways on a daily basis, and they bring those issues forward, and often to me and to other clinical nurse specialists, and then we can sort of move things forward in the system and pull things together in a way I think that's very helpful, and I think it allows people to have that voice and allows the practitioner to have a voice. And we work very closely on the ground with the public health nurses and with other providers within the public health system in Winnipeg. That's all I've got.
Excellent. Thank you so much. I think you can see from this response is just the breadth of what practitioners are doing to address health equity and the social determinants of health. I can see some questions coming in. We will take the next question from our presenters, and then we'll start to address some participant questions. And so, Connie, Lee, and Christine, you all talked about what you do in your work or what you've done in the past. And I think in speaking about that, you raised really interesting issues around building capacity, working directly with a range of programs. Can you talk about how students or early professionals can start to integrate health equity into their everyday public health practice? And Connie, we're going to hear from you first, then Lee and Christine.
Thanks. I think early career folks and students can do it the same way everybody can who's further into their career and older, except that you may have less authority. So you may be pushing against middle management or senior management who doesn't have the same worldview that you do and doesn't bring that same commitment, and hopefully we'll see that shift over time. But I think one of the biggest things, a lot of early career folks will start in positions that may be more what I'm going to call direct service. But I think everybody at any position in a public health department, a community health center, a community NGO can be an observer and report back. And I'm going to share a little story. A long time ago in Toronto, before homelessness became the issue it is, you can tell how old I am, one of my nurse colleagues came into the office and was concerned because a homeless individual had taken up residence in a transit shelter. And we realized, she'd stopped to talk to him several mornings, and we realized that he wasn't getting any service. by her raising those questions, it eventually led to community health centers and public health figuring out how to use alternate addresses of shelters or community health centers so that people could collect welfare or they could take advantage of other government services that they didn't if they were without an address. And it also helped contribute to a multi-agency group that really focused on individuals living with transient housing and without an address, and what did it mean to be without a fixed address. And it led to some very good reporting and some data and some policy recommendations that over the years have really turned into policy. So if you can be those eyes and those ears and suggest an idea, you're right in there. Integrate lived experience. Remind your managers to invite people who have lived experience of poverty or of social isolation or of disability or whatever. I think about back to when I chaired a roundtable on prostitution, and prostitutes were at the table with us, as well as neighborhood organizations, as well as police and justice. But in many jurisdictions, the prostitutes would have had no voice. Insist that equity be measured. I've seen some notes coming up about how important it is to do that measurement and to disaggregate data. Absolutely essential. We have some resources that we'll post on doing equity-informed reporting, but we are seeing improved reporting across the country, not without challenge, but it's happening. I think the thing is to make sure that you have a cohort of people around you so that when you do think critically and you get challenged back, that you can hold steady on your challenge to the system and to challenging power and authority to help shift their patterns. And you can only do that when you have people around you. And I think part of that is to have people around you, is to have models to learn from others. I think about, a peer of mine who you may know was Kathy Crow. We started as young feminist health workers, went in fairly different ways, but I always counted on Kathy to keep challenging me. Cindy Blackstock has been a recent hero. Individuals in the formal public health system like Corey Newdorf in Saskatoon who've been able to take this kind of work very far in the formal system. And be informed about each policy piece that it could be. I can think about it was during the SARS crisis in Toronto that, not me, somebody else kind of noticed that the impact of SARS was totally discrepant depending for different workers, because most of the nurses who were most exposed were part-time, temporary, transitional, and many of them were immigrant nurses and nurses of color. So very disproportionate exposure. Wonderful research coming out about how cutting back on fluoride and water has different impacts on middle and upper income children than it does on low income children. BC has now said, okay, they're going to make IUDs available free after abortion because IUDs, as a very effective kind of birth control, are very expensive now. They're not accessible to low income people. But if you can take a moment of other medical service to say, we'll make an IUD available for anybody coming through, you start to even out the cost barrier to that. So I think I'll end there.
Well, thank you, Connie, for those comments. So we're going to hear from our next speaker. So if you move in the slides, yes, there we go. Thank you.
Yeah, I'm trying that. There it is. Okay, so in our region, we have, I think we're fortunate in that our strategic plan actually identifies equity as a value, and I think that has been helpful. And we know that equity really is grounded in public health and in public health nursing. And so part of what has been helpful, I think, from a nursing perspective, is that a colleague of mine, Dr. Cheryl Cusack, worked on developing a professional practice model for nurses, and one of the pillars of that is really equity and social justice. And so that has been really instrumental in sort of shifting practice for public health nurses to focus on equity and social justice, and rather than we were sort of caught in a doing postpartum follow-up, and it was sort of getting kind of primary care-ish, and we're trying to move away from that now. So having a strategic plan that equity is part of, and we have that in public health as well. We have our own strategic plan as part of our program, and equity is right in there as well. That's been really helpful. We're also fortunate that we have an individual, much like Christine, who is a Health Equities Initiatives leader, and so she takes a role in really on a number of initiatives, and she's involved in communities regionally, and she does a lot of work to promote equity and connects different players, different stakeholders, and she's really involved in some of that work. And also because we have a focus on Indigenous health and equity so entwined with Indigenous health, our equities initiative leaders also involved with some of that work. So I realize that not everybody has that happening where they maybe work. So I think as a student or a new practitioner, really it's important to find your allies and to choose them wisely, because they're not only your sounding board, but they will also be your support. I can tell you that I find this work sometimes very exhausting and difficult and frustrating. In public health, I have a background in hospital and primary care, and then coming into public health, it was very different for me, and I found things kind of moved at, sort of glacial speed. And so I really need that support as a practitioner. So, and finding people that have the same vision as you do is really important as well. I think there's inequity all around us, and it's just a matter of paying attention. And you won't have difficulty seeing those opportunities or finding them. And, you can't take on every battle, but you can identify where inequity exists, and you can be part of solutions. If you can be involved in certain things like practice councils, we have practice councils for nurses and for our Families First home visitors. We have a program here for families that's called Families First that work with young families and promote bonding and attachment and child development. And a lot of issues come forward through those practice councils. So for example, we have the Manitoba Youth Center is a place for youth who are experiencing encounters with the justice system. And typically those youth are involved in the child welfare system, and they are at-risk youth. And the nurses that attend the Manitoba Youth Center really identify that there is a need. There's a lot of younger boys in there, young men in there who are, at risk, and our province doesn't cover the HPV vaccine. So they thought, this is not right. There's something that's not right with this. So they brought the issue forward to practice council, and then public health nurses around the table all agreed that this was something that really was not equitable and that we needed to address it. So they were able to bring that forward, and through practice council brought it forward to the person involved with the immunization program. A medical officer of health got involved, and through that work they were able to go to Manitoba Health, and now Manitoba Health has agreed to cover vaccines for that group of youth. So those kinds of things happen every day. I mean, I can tell you that we do things like that quite often, and so it's a matter of seeing it and just working at it and not letting it go and not being satisfied that that's the status quo and that things can't change, because things can change, and we change things sometimes slowly, but they do change. So I say be persistent and keep on pushing forward.
Great, thank you so much, Lee. One of the things you said was find allies and choose them wisely. It really resonates with Connie's comment around building support and having models to learn from. Thank you. We're going to hear from Christine Johnson next.
Great, thanks for that. So the areas I wanted to focus on, sort of are built around some of my experience recently working with frontline practitioners in particular, but then also thinking about the many years that I've engaged with students at various levels. And just wondering if the slide can be moved, I think, ahead one. Perfect. So I'll focus on kind of three main areas that I thought I would emphasize. So one of the areas that I feel is a really important skill to hone and an area of practice that we can develop is to strengthen our ability to communicate and talk about health equity and the social determinants of health, and talk about it in a way that resonates with a broader array of audiences. So we do tend to talk in our kind of public health speak, which doesn't always resonate to the multi-sectoral partners that we need to actually, that we're trying to convince that there's an issue that needs to be addressed. So looking at communications and strategic communications and how you can build your skill to do that is, I think, really key. So one of the things that that I've seen is that people really, they talk about, okay, well, I really wholeheartedly believe in equity and I want to make a difference, and I was at this committee meeting, this issue came up, and I didn't really feel prepared to address it, even though I knew that there was a deeper issue here that needed to be talked about. So I do think that kind of honing that skill would be useful, and there are some tools that exist to help us do that, and one of them is pictured there, the Shifting the Conversation tool, which was developed in our area. So I feel like that when we do, one of the other things that happens, or that I've seen happen by deeply engaging in thinking about how we talk about the issues, also helps us sort of dig deep about what is our real own understanding of health equity in order to talk to someone else in a way to help them understand. You have to have a really solid grounding yourself. So it helps you do that, and you learn by practice. And it helps us also see sort of what is underlying our understanding. So what are the values? So what does it mean? What do we think it's rooted in? And how do we think we go about addressing the issue? So communications is one. The other big step that I think for early career professionals in particular would be to really understand your work and articulate it and frame it within that metaphor of the stream, so downstream, midstream, and upstream. And in particular, to do this in a way to make explicit the role that you are playing. So again, some of the challenges that I've seen is that people often they see health equity work only as maybe upstream work. They don't feel like it's part of their role, or that they're supported within maybe a service provision role to do equity-related work. So I'm encouraging people to look at their work and look at the multiple ways that we can address health equity. So maybe is your work about mitigating the effects of inequities and ensuring people have access to services? That's health equity work. Maybe your work is about shifting conditions, shifting the environments in which people live. That's also equity work. Your work may also be more working on the structural forces that are driving the inequities in the first place, or what we think of as the more upstream work. I've seen some challenges and difficulties with people feeling like they're not doing equity work. So being really explicit about what your work is and where the opportunities are. And then I think what that also helps us to do is to push the work upstream. So to be really clear, okay, this is what we're addressing. This is what we're not addressing. How can we sort of fill those gaps? So I do think that that's part of the picture, or something that would be really helpful when you're thinking about your work and in conversation with leadership. In the everyday, some specific things you can do is challenge those assumptions about what causes poor health and illness, and constantly challenge that. Identify it when it happens. So when you're in a meeting or in conversation with a colleague, or even if you're reading an article, really looking and thinking, well, wait a minute now, is this, focusing too much on individual lifestyle or behavior, or how are these messages and this evidence being framed in a way that it makes it appear that the real issue may lie at the individual level as opposed to the more structural determinants. And then to reinforce what Connie was talking about, as well as Lee, that the lived experience is so important, and bringing that voice, and also being careful not to get so far removed from the real community that we don't have that relationship or that ability to bring the lived experience into our programming and our planning. That's really critical. And so being willing to get out there and actually dig in the dirt in a community garden with someone is actually really important work. So the last piece of advice I'll offer related to digging and on the theme of tools is to use health equity focused tools. So we have a ton of tools out there. We have a lot of tools, and again, what I've seen is that people hesitate. They think, well, I'm not really sure if I'm going to do it right. I'm not sure if I'm going to have all the answers. You're not going to. Nobody's going to. The purpose is to work through that tool as an approach to learning about an issue and thinking about an issue critically. So I would encourage people to try out different tools, but in particular, not just try them out, but make a concerted effort to reflect on how did that work, what did we learn from that, and to share that experience and knowledge with your colleagues and your peers so that we can learn together. And I think, again, the suggestion there around finding your allies and your role models and your people that think similarly, that support what you're supporting, so that you have more voices to say, okay, let's try this. And it feels a little safer to dive in that way.
Excellent. Thank you so much for that. Christine talked about the resource shifts in the conversation. We have a link to that in the chat box, and we'll also include that when we send out further communication. So we're going to just take a few questions. So there was a question which was for Christine. I think given your connection with the NREACH project in Nova Scotia, you may have a sense here. The question is, where do environmental and social determinants overlap? What is equity versus environmental justice? I'm wondering if you can talk a little bit about the work you're doing with the NREACH project and Dr. Ingrid Waldron's team.
Yes, I saw that question. It's a great question, and we're in pretty early days in terms of looking at that work, and so I would definitely say I'm not sure I have my head fully wrapped around the the slight nuances. But when I look at the work of the NREACH project, which basically looked at communities within Nova Scotia, in particular African Nova Scotian and Indigenous communities, and then overlaid through a GIS mapping process the location of sort of dumps or waste facilities and other toxic polluting industries, and found a very clear association between where those were located and where those communities were located. So you see a strong correlation there. And so within that work, we were able to see that the idea of environmental determinants of health, or looking at sort of environmental pollutants and who's most at risk, that it follows similar lines, that it's not accidental, it's not random how these environmental toxins get distributed, that it's inequitable. And so for me, I mean, again, I don't know if I'm touching really on the nuances between sort of the words or the terms and the definitions, but it is about kind of bringing to light the burden of environmental pollutants that are experienced by various populations, and then taking that further and looking at, well, why is it that would be happening? So why is it easier to establish polluting industries within African, Nova Scotian, and First Nation communities? And looking back to issues such as racism, colonialism, who has power and voice, who has the most political influence, who needs the jobs, so they're going to say, yes, put that dump here because it's going to generate jobs. So to me, that's where they intersect.
Great. Thank you so much, Christine. And on the NREACH project website, you can actually access a lot of the mapping data, which includes things related to how far communities are from waste as well. It also connects the location of Indigenous and African Nova Scotian communities 2 and overlays that with the material deprivation scale. So all those tools are available on the NREACH project website. Thank you.
Sume, if I can add one more thing. I think one of the things when we're thinking about justice, whether it be social justice or environmental justice, there's been some really neat work done with Latin American activist scholars and in partnership with Canadians, and looking at how an approach around social determinants of health, many people interpret, without a strong equity focus, interpret as trying to influence a set of risk factors related to living and working conditions, which is important, rather than also moving upstream, if you would, to look at the social determination of health. How does the societal frame, how does the policy frame, how does the positioning of which communities and populations have voice and which don't, so that the way in which all of that determines health through the processes. And so it becomes much more equity sensitive and more justice oriented to think about policy and the space or the intersection, the praxis, if you would, between policy and lived experience. And so I'm going to post one article about that work that Jerry Spiegel from UBC and Annalie Yassi from Canada have done with Jamie Burrell, who I believe is Colombian, but I kind of forget. Okay, thank you.
Thank you, Connie. So Lee, can you just clarify, you shared a map of Winnipeg which had male and female life expectancy, and I believe that was by neighborhood area. So this is a question about, can you just talk about how Point Douglas compares to other parts of Winnipeg?
Sure. So when I was looking at maps, I wish I could have found something that sort of layered other things, or I could find a really cool way to, show different things. But this is the best I could sort of come up with right now. So the maps really show the difference in terms of life expectancy for men and for women. And you can see that Point Douglas is really the community for, if you're looking at the male life expectancy map, it's the community there in the red. And then on the orange, the other map, so the female life expectancy is on the right, and then the male is on the left. So the red little area in the middle, and then there's two little orange areas beside it. Those are the areas. One is the Inkster community area, and the other one is the downtown community area. And those areas have the greatest gaps in terms of health inequity. So in Point Douglas, for example, men live about 15 years less than males living in other community areas, in the green ones near the bottom. And on the female life expectancy map, you can see that there's about a 20-year, I think it's about a 19 or 20-year gap. So, and really what that is too, what that indicates, and in Point Douglas specifically, Point Douglas experiences higher rates of suicide, higher rates of chronic disease, higher rates of infant mortality, and we're talking infant mortality will be 4 times that of the rest of the region. So it's significantly different. It's a very significantly different community. It's a smaller community. There's a lot of people per square mile, so it's a little bit dense. There's a high Indigenous population in that community area. Housing is very poor. I mean, it's there are high rates of poverty, more single parents, single mothers and fathers living in Point Douglas. So all of these social determinants that add up to basically having less life expectancy at the end of the day, and that's what that map is showing. So the other areas are just different community areas. Our cities divided up by community areas in public health, and that's how our public health teams are divided up, or by community areas primarily. Is that helpful?
Great, thanks for that, Lee. So just one more question, and then we'll move to our last discussion point. So a number of you, Connie, Christine, spoke about the importance of data. And so it's a question about how do you advocate for robust data collection? In Ontario, as a very specific example, there is now an act, an anti-racism act, which requires that some ministries collect that information. The Ministry of Health decided to opt out. So in situations like that, what can public health practitioners do to actually make sure that we're collecting the data we need? Connie, you want to give a stab?
Sure, and I'm hesitant to talk about the Ontario situation because I don't know that detail. I'd been looking forward to the anti-racism directorate's work. Certainly public health, some players in primary care, and some of the more, well, the Toronto Central Lynn, I won't say, I won't shape it, have been working on this issue for a while. And NCCDH, particularly SUME, have been linked with a couple of different initiatives. It would not be the only example that we've seen where there's hesitation to move rapidly to sharing racialization data. We're seeing some of the same concern with some equity data coming out of the Public Health Agency as people are cautiously trying to figure out how to work with data, and I understand that caution, but it's still a challenge. So I just think it's absolutely critical to disaggregate data where you can and bring those pieces to it. I think it's also really important not to bring a race analysis if, in fact, race is rarely the driver, racism is the driver. So race data may not tell you about patterns of racism. You can infer them from, the kind of data that Lee was just talking about, that racism is part of the mix of societal challenges that result in Point Douglas, the facing some of the challenges that it does, and also some of the resiliency and the community mindedness that happens there. So when Saskatoon Public Health first did disaggregate data similar to what Lee showed for Winnipeg, they very specifically spoke about income and chose not to speak about race or indigeneity in terms of that data. And they were able to make some very significant changes in some public health services and changes, therefore, also in, let's say, immunization rates is the most clear example, by shifting the public health interventions based on income. So real challenge, but disaggregate as much as you can and find out ways to, I think public health just has to keep naming the importance of that and to model places that have done it well. That was a long answer, I apologize.
Okay, thank you, Connie. So Danielle, can you put up our next poll? So just want to get a sense from you. So our presenters are going to talk about leadership. It's an area which we've been exploring at the center for the last couple of years. So I'd like to get a sense, how do you think about leadership? So is leadership a function of your position in an organization? Can anyone demonstrate leadership? Are leaders born or are they made? All right, great. Thanks. Everyone is responding to that poll. So this is really nice to see. So about 92% of people on the line are saying anyone can show leadership, which is really the approach we've been taking here at the NCCDH. So Lee, I'm going to ask you to get us started here and just give us a sense of how students and early career professionals can demonstrate leadership in their work.
Sure. I'm glad to see that so many people think that anyone can be a leader, so that's really great. I think that you have to see yourself as a leader, and someone said to me recently that it was actually somebody who's a youth said, he wishes that people would quit saying that the youth are the leaders of our future. They're our leaders right now, and I totally agree with that. The best way I think I can demonstrate leadership is through an example. So one example I have, and this picture relates to that, is there is public health nurses in Point Douglas who were working with a group of nurses from a community clinic, very inner city sort of type services, and they recognize that, the moms in Point Douglas have really low breastfeeding rates. So, and basically the history of that is that our breastfeeding support groups and clinics were done historically through paired community areas. So in the Point Douglas community area, we were paired with downtown, which is, fine because downtown seems like very core, but there's another downtown team that's a little bit out further, a little bit west, and that is where the clinics were held and the support groups were held, and that area of the city is very much, I don't know, it's kind of like a hipster area where people there's been a really resurgence there, young families there, and they've all got like high-tech strollers and that kind of thing. And so for our women, it was really too far for them to go. It was at least 2 bus rides, sometimes 3. And then when they did go there, they just didn't fit in. It wasn't their kind of thing because they have very different life experiences and they were not comfortable. So they brought this forward to us, and they were saying this isn't right, and we're going there, and then, no, our moms don't go. I think I looked, and there was 3 moms had gone in about 8 years, and so it was really not meeting the needs of our community. So when I did a review of the literature, I found that a peer model of support was probably the better way to go in maintaining breastfeeding. I had lots of examples from Indigenous communities. And I really felt, and I know that knowledge is kept in and by our community, so I felt that we had to return it back to our community. Now the problem was that our program wasn't really on board with that because that's not the way that they did things before, and they had a funding model, and so there was all this other stuff going on, and they were very resistant, and that we couldn't do it this way, and I heard that, peer models don't work, and I heard a lot of other stuff. So I decided that this was a battle that I was willing to fight, and I said to the team manager, I said, you know what, I'm willing to die on this hill, and we're just gonna push this. So we used the argument of equity and access to services, and certainly the women in our community were not receiving the same services that women in other communities could receive, and it was really about equity. So the director that I worked with at that point was very open, and so she said, yeah, let's give this a try. So we did conduct focus groups, and we were told by the community loud and clear what they wanted. We partnered with a Indigenous community-based organization, and now the group that we have women attending, we have fathers attending, the grandmothers attend, prenatal women attend, and in one case we had a prenatal woman whose boyfriend wasn't supportive of her breastfeeding, and they came to the group, and the men in the group, talked to him and said, hey dude, this is the way to go, and you got to support her. And so she ended up breastfeeding. They've had a naming ceremony. They participated in a number of culturally based activities, and we presented at this Indigenous Health Symposium in November where the public health nurses attended, the public health nurse involved attended, and so did the family that one of the families that attends the group. So the point of this story is that none of this would have happened if the nurses on the ground didn't, identify that this was something that was a gap and that our families were not being served in the same way. And if they hadn't brought it forward and they really led it, they pushed it. And so what they did and what they saw, there was clearly inequity there, although they didn't describe it that way then. They didn't have that language. But they knew that this was something that had to change, and they knew that this was something that they had to make changes in. So I say that as students and as new practitioners, you're coming into public health work with a really fresh pair of eyes, and I think that's really something because you'll see things that maybe, you know, those of us that are more seasoned or that have been around longer aren't going to see, and if you're on the ground, even more so, you're going to see the inequity that happens in the communities. And I think it's really imperative to bring that forward, and I really encourage you to bring it forward. And as we've all said, I think, you know, find your allies, find the people that have the same vision and support what you support to help you get things going. If there's one thing, though, that I would add, and Connie and Christine have already mentioned it, is do not forget about the community. Don't always include them. Always have them there. Always ask them and include them in everything, and don't ever silence them. Let them have their voice and shift the power so that the community is able to have their voice as well.
Excellent. Thank you so much, Lee, for sharing that story. Christine, you're up next.
Mm-hmm. Great. So in terms, I was really happy too to see that people feel that leadership is an action anyone can take. And that's to my first point there, and it is all of our responsibility, and leadership can take many different forms and look different, and there's lots of opportunity for it. So some of the specific strategies that I wanted to offer up that I've used myself or have seen many students use and early career practitioners are listed here. So one, of course, is to get involved. So find whatever way you can to get involved in an organization or an initiative that is focusing on an equity issue that you're interested in or that you want to learn more about. And I've just put a few examples there. So the Public Health Association, which most provinces would have a Public Health Association, is a great way to learn more and get involved. And if you want to demonstrate leadership, one of the things you can do is apply to be on a board or to be on an executive, and you don't have to take on a super intimidating role. Start as a secretary. So back in the day, in my early days of my career, I was the secretary of Food Secure Canada in its kind of first couple of years in existence. And my experience has always been that these organizations are very excited by participation of students and early career professionals, and that they provide a really key avenue for capacity building, a safe place for you to gain experience and test out some of your skills and abilities and contribute, and offer a lot of opportunity to build that and advance in that way. So I would certainly encourage that kind of involvement. Just generally as well, I don't think there'll be anything too surprising here, but one of the key roles that I see is asking the good questions and raising issues. And again, back to the earlier comment around the tools and the many tools we have out there, there's already lots of pre-made questions for you that you could kind of bring to the table. But in asking questions and raising issues, one of the things that has worked really well in my experience has been to approach that from a place of curiosity. So when we ask things in a way that's curious, and that, well, I wonder if this is what the experience is for everybody, or if I wonder if this particular issue plays out the same in all of our communities that we service, it opens it up in a way that's safe and that creates room for dialogue, as opposed to an adversarial, I think we need to maybe do it this way because. So just being curious and asking good questions is going to be another way to demonstrate leadership. Engaging in the ongoing reflective practice and both looking for opportunities to do that as well as creating opportunities to do that. So I've heard mention of practice circles or communities of practice and different, learning forums and that kind of thing. So either creating or participating in those where they exist so that we are able to demonstrate our interest and contribute to that ongoing learning and shift in practice. And then, of course, being a lifelong learner. So any training modules that are made available to you, learning opportunities. Again, step outside your comfort zone and learn about an issue that's maybe completely new to you. And in particular, if you're feeling like, oh, you know, I don't know if I really want to do that, I don't feel like I know enough about it to step in, that's where you need to inspire yourself to step in, because that's where you're going to gain the most. And that, to me, demonstrates leadership around health equity.
Great. Thank you, Christine. Connie.
So I think Leah and Christine has done such a perfect thing. I don't have much to add. I think it's part of that piece that I think all three of us have talked about, of how do you create your network and the people who will champion you. So part of it, surround yourself with other leaders. And therefore the encouragement to step into active roles will be there a lot of the time. In addition to professional associations that you can join, maybe it's actually starting something within your own institution if you're still at a university, of a mini conference. So it might be a learning event. A mini conference might be a network of people who support each other, or a reading group to do learning. I'm sure you all have spare time on top of your master's and your PhDs or your undergrad, but sometimes that committee can be an advocacy. And I think back to when I was at Toronto Public Health, I got invited to be part of a University of Toronto graduate student initiative to try and integrate equity more into training for, in particular at that point, for medical students. So helping medical doctors see part of their professional role as being advocates. It didn't go anywhere at the time at U of T, but it was a very important, I think, learning group for the folks who lobbied for it. And we learned a lot about more successful ventures that had happened at other universities. So that type of thing. And I think that itself, by practicing an advocacy role, you also learn part of doing that as your professional role, whether it's a paid portion of your work or whether it's as a volunteer. I think the other thing is to think about when Lee is talking about engaging with community, make sure that through your own school research-oriented work, you learn about participatory research and action work, and then figure out which kind of group or academic mentor can help you do a piece of research that is actually in partnership with lay researchers who come from community groups alongside you. That will stretch you in a huge way. And I think one of the other things, we encourage people to contribute to the evidence base, because the evidence on health equity practice and what's effective is pretty thin. And it doesn't need to be a peer-reviewed article, although that would help your resume. It could be a blog. It could be a personal reflection piece that you find a place to share. And so I think all of those things will both position you in leadership roles and help you hone those leadership roles. And I just want to echo Christine's thing about volunteering with some other group. And I'll name that our online community from the NCC for Determinants of Health, Health Equity Clicks community, will be sometime later this year moving into some volunteer engagements where we have volunteers help moderate and keep the site more active. So watch again for those opportunities. Thanks.
Great. Thank you so much, Connie, Lee, and Christine. I think in all of your comments, it's been really resonating with the work Claire Becker did in her PhD looking at public health leadership for health equity action. In her work, she found that successful leaders were visionary, passionate, charismatic, able to inspire others. She talked about leaders as being effective communicators, and Christine, you really drew on that in your earlier comments. Leaders are also very connected to the community, which They were trusted, respected, and credible, and they had their values which were oriented towards social justice and solidarity. Additionally, successful leaders were humble, caring, and patient. And I found that a really nice way of thinking about the areas where you may want to further develop your skills or your knowledge in related to health equity action. You can read more about that in the full report, which is on our website. So this is Tom, we have some time for some more questions from the audience. I'd like to invite participants to respond to a question from one of our presenters. And so Christine has a question about models which you may have observed in your practice. You can send in your response through the chat box. So Christine's question is, what do you think are some ways public health could create opportunities for students and early career professionals to engage in leadership for health equity? Are there any great models you know of? So we usually don't do this, but if you'd like to respond to that question, just drop your name into the chat box, and I'm actually going to get you to open your line and respond verbally. So while you're thinking about that, we'll wait to see if we have any responses to Christine's questions. What would you need? How can the field support your work better? And we will be sharing contact information of our presenters following this. Thank you. Okay, so we are still taking questions. Connie and Lee, Christine posed a question to the participants today. Do you have any questions for our participants?
Not immediately. I want to know your questions. Thank you.
All right. Great, thank you. So one of our participants says there are no great models that she knows of, but she wished there was a way to facilitate connecting early career professionals with people who have more experience and similar interests. So she's suggesting a more formal mentoring and matching system. Thanks for that suggestion. All right, great. So I'm not seeing any more questions come in. Danielle, can we have our next poll up, please? So I'd like to know, our presenters really shared a wide range of experience today. Based on what they shared with you, can you think about one new way you can show or demonstrate your leadership for health equity? So a number of people are saying yes, some people are saying no, and a few people saying maybe. All right, thank you for that. So for those people saying yes, I think that's really great. If you're in the no or maybe boxes, I'll just encourage you to spend some time reflecting on today's conversation and also taking a look at some of those resources which have been shared, and also getting in touch with presenters directly if you have more questions for them. I'm sure they'll be happy to respond to those. So I'd like to invite Christine, Lee, and Connie in that order. If you have any wrap-in comments for our participants today.
Connie here. I actually think that as a field, public health has not done superbly at bringing younger people along. And so I think we have a gap in, I think we have fewer people in formal leadership positions than we should, who are, let's say, in their 30s, 40s, even 50-ish, because a whole lot of us who are 60 to 70 stayed in leadership positions a long time. And I don't think we mentored well enough. It's going back to that question of is there a formal mechanism on to mentor? And so without formal mechanisms, I just really encourage you, we've all said this, you know, surround yourself from people you can learn from. And so who is it that you say, oh, I would like to learn from that person, I would like to follow them, I'd like to know more about how they've done, and at a minimum, just reach out. At a minimum, those people are going to say, yes, they'll have coffee with you and chat with you, and through that, there may come another connection, a network connection, and at best, you're going to have a longer-term connection with that person. Do that cold call, and I just really, that would be my encouragement to you. That's it.
Thank you, Connie. Christine.
Yeah, I would echo what Connie said there. Definitely, when I think back to kind of some of my early days, there were several people, some of whom are on this call, who I thought, I want to be like them. And so I got to know them, and I volunteered with them, and I studied with them, and any other opportunity I could have to be engaged and to learn about their work. And so I think I am still particularly interested in kind of exploring more. I agree that we could make some more concerted efforts, I think, to think about how do we sort of lift up and encourage students and early career professionals with this passion for health equity to bring them in and to provide the opportunities for them to get engaged and be involved in a meaningful way. So I am really curious to hear from students about what they think, and early career professionals, what they think would be the most meaningful approaches for that. So yeah, you're here, you're passionate about the issue, and you're interested, and just kind of keep that going and follow it, and it will come.
Thank you, Christine. And Lee, you get the last word.
Yeah, I would echo what Connie and Christine have said also, and I think that if you really have a keen interest in public health, that you need to pursue that. I know that when I was in nursing, I was really discouraged from pursuing public health as a career because it was like, well, you're not going to get a job and all this other stuff. So, but if it is something that you are passionate about, I think, you pursue it and find people, like they have said, find people that are doing the work or that inspire you or that sort of thing. I think also that as someone who's, I'm not sort of old hat to public health, but I try to find, I try to look for people that I see something in too, like in my own practice, and I'll see nurses or families first home visitors that I work with that I go, oh, there's something there that's really special. So I say to seek those people out as well and try to encourage them, and sort of sometimes you drag them along, but I think, it's making those opportunities for people. And I also think that, I don't know about other organizations, but in our organization there's this hierarchy, and I think that that's something that we have to flatten out and do away with because it's not really serving anybody. So I would like to see that happen, and it really makes me sad that other practitioners feel disempowered and they don't feel that they have a voice, and that, nothing that I say matters and nobody's going to listen anyways, so why bother? But that really doesn't sit well with me. So I think as organizations and as sort of a system, we have to get rid of that hierarchy and all work together.
Great. Thank you so much for those comments. And I think, Lee, your pieces really speak into the importance of us pulling in those health equity values and those social justice values in how we organize our public health organizations themselves. And I'd like to thank our presenters for being on the call with us today, and all of you for joining us. Before you go, I'd like to get a sense of who was on the call today. Are you a student? Are you currently working early in your career? Are you a faculty member? What role are you in? Thank you very much. And you will receive an email following today's call with an evaluation link. Please do take a few minutes to provide us with some feedback on today's session, and also give us a sense of any other areas you'd like us to explore further. So thanks again for joining us today, and happy spring.